Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to our podium session today. We have a special guest with us, Dr. Farshid Ariz. How are you, doctor?
Very good. Thank you, Dr. Shah. Glad to
Thank you
be
so
here.
much for joining us.
My pleasure.
Very glad to have you with us, Dr. Ariz. You have a very interesting topic you're going to speak about today. TMD, sleep apnea, craniofacial pain. That's a very hot topic these days, and you have sort of established yourself as an expert in this. I think our audience is going to be very receptive. But before I go in further detail, I'd like to make a quick introduction of Dr. Ariz, who's a 1989 graduate of Boston University School of Dentistry, where he received his DMD degree. In 1991, he received a certification in Advanced Graduate Studies in Periodontics. He is an assistant professor to advanced periodontics of over 25 years at Ostrow School of Dentistry of University of Southern California. He's also a diplomate of the American Board of Craniofacial Pain, and he has extensive training in orthopedic craniofunctional dysfunction. His expertise includes implantology, aesthetic implant surgery, aesthetic periodontal therapy, and full mouth reconstruction. Dr. Ariz is also a member of a host of organizations, including the American Academy of Periodontology, Western Society of Perio, American Academy of Craniofacial Pain, American Academy of Dental Sleep Medicine, and several others. It's an incredibly huge honor to have you with us, Doctor. I've been following your work for a few years, and it's very interesting to see dentists branch out into other areas. So tell us a little bit about your background and how you ended up branching out into this space particularly.
Sure. Thank you. Thank you. Well, first of all, good morning, good evening, good afternoon to all your members from all over the world. It's an honor to be here presenting along your top presenters in the past, and I appreciate the invitation. Hopefully, we can do this more. But I started, back in 1989 when I graduated from dental school. I go through a little bit of my bio in the past, but kind of like learned and enjoyed branching from periodontics into different field, which is not really as a specialist yet, but a lot of universities, a lot of academies are picking up the dental sleep medicine part. But where I come in, we are understanding that how craniofacial head and neck pain and dental sleep medicine branches or is a bridge between dentistry and medicine. And we have almost 67 worldwide centers, which are branched out to different parts of the countries, Australia, Canada, UK, Dubai, and mostly in US. So pretty much what I'm talking about today is going to be exactly what these centers are able to achieve and do. It gives me a great pleasure to see the patients coming with pain and leave happy without the pain. And today I'm going to be talking a little bit about overall synopsis of what I'm doing or how I can help them.
Very lovely. That's interesting. So would you say that after the pandemic, I think so in my practice, after the pandemic and the time spent away from, your regular follow-ups, I'm having a lot of patients that have issues with TMD and sleep apnea, and I tend to refer them out because I don't particularly understand it. I don't know the proper treatment protocol. And I think a lot of my colleagues have the same issue. So perhaps if you elaborate on how to approach these patients for someone that doesn't have any experience in the space, would be really appreciated.
Sure. Well, the body goes through survival mode basically, and it's a little bit of neurology, a little bit about what the body does best to survive in any situation. And for us to be able to detect these things, and the clues and the signs are intraorally visible. Again, there are a lot of different topics and lectures that I can present about different issues of it, but mostly comes down to if you look for what you are looking for, you'll be able to see what the problem is. If you don't, then you totally will bypass that. So it's not something that is taught in dental schools, like preclinical or during your 4 year of dentistry, because we have so much stuff to learn in dental school, crowns, extractions, root canals, that really don't have time, or no schools really devotes the time and education to making sure that temporomandibular disorder is covered as far as a continuing education curriculum. So my goal is to be able to educate and flourish my knowledge so that the dentists understand, hey, you know what, there's a problem with what I see here. So yes, exactly as you said, refer them out, refer them to the right doctor that can and be helped by their services, sure.
They did spend about 5 minutes in dental school and told us to just make night guards for everything. I'm sure, I'm sure it's probably not the right solution. And you'll teach us more about that.
Yeah, well, I mean, I have a whole different lecture about the why night guards don't work, and it's interesting because I mean, there's not a day that I get a patient comes in with a night guard and they say, hey, you know what, I'm not getting any better. Well, so I got to educate the patients from zero to hero in less than maybe 45 minutes, an hour or so. So my consultation with patients takes literally about 2 hours. And I go through a whole series of CBCT, intraoral photos, posturals, all that, so that they understand what's wrong with their body and how their body is trying to defend them through different variety of issues that they may have. And that's really an awarding for me, and it's much more glorious for me than periodontics. I mean, I love periodontics, soft tissue, sinus augmentation, implants, don't get me wrong. But this is totally different. I mean, it's amazing how glorified it is.
Yep, I think I heard there was a law instituted in California that now you have to screen patients for sleep apnea symptoms. So this is going to be quite beneficial. And also, if you see the signs that you need to review a sleep study or order one, and those kind of things. I've been playing with Herbst appliances a little bit, some tap appliances. I've had some good success, especially if the patients are coming off, the big thing that they put on their face with the CPAP machine. But okay, basically, I'm going to go ahead and disappear. And if you want to put your presentation up, Doc, we're very much looking forward to it.
All right. So let's start. Can everybody see this? My view?
Yes.
I think so. All right, good. All right, well, welcome again. I'm very happy to be here and taking over the floor. Thank you, Dr. Shah. And again, as we've been talking about my background, I'm a Boston University graduate, and most of my practice is limited to periodontists, and I still do periodontic therapy and dental sleep medicine and craniofacial head and neck pain and temporomandibular disorders. I am a board certified in three different organizations, Diplomate of American Academy of Craniofacial Pain and Diplomate of American Academy of Craniofacial Dental Sleep Medicine. I'm also being a member of board of Diplomate of American Academy of Craniofacial Dental Sleep Medicine. So and that's going to be very, very exciting for me as a new board member into continuing education courses that I'm going to be hopefully inviting doctors to come talk about dental sleep medicine during my 1 year of membership in that organization. And I belong to all these organizations. What I speak, both periodontics and both craniofacial head and neck pain, Los Angeles County Medical Association, American Academy of Craniofacial Pain. And now I'm into 30 years of being a clinical assistant professor at USC. So over there, I'm basically working with the residents as far as teaching them the ins and outs of periodontics, everything that a dental residents and periodontics needs to know. So it gives me a great pleasure to see the new doctors coming up with the understanding of how periodontics have changed. And about 60% of my practice is devoted to craniofacial pain. I still am a full-time periodontist as well. And it's my passion because I love treating patients, both periodontics or craniofacial head and neck pain, because it gives me a beautiful joy to see the patients be happy. So today, the topic that I chose was pretty much in general. There's so many different branches that goes into why things happen. So we're going to be talking mostly about why patients are suffering from temporomandibular disorder and craniofacial pain, and how to identify signs and symptoms of temporomandibular disorders, because I think it's important for us as a dentist to be able to see, hey, I see something, is that normal or is that not normal? What should I do? Where should I be referring these patients to? Incidentally, I'm going to be doing a lot more in-depth presentation coming up in May 11th at UCLA, right here in Los Angeles, that by all means, if anybody is interested, if you're local, please feel free to contact me. I'll have my email at the end of the presentation. You're more than welcome to reach out to me. And I think we still have some rooms for patients or doctors that want to come in. But basically, I'm going to be talking about more about a little bit what I'm talking about today, understanding craniofacial head and neck pain. So I think it's a great topic for anybody that is more interested to understanding. So right now, my practice is limited to temporomandibular disorder, neuropathic disorder, primary headache. I'm going to talk about that. Muscular disorder, undiagnosed pain of the head and neck. What is it that we should be looking, or what is it patient that are complaining about? And airway, functional breathing, sleep disorder. So very little bit of time is going to be on airway, because that's a whole different, maybe 2 hours or so of a presentation. But majority of what I'm going to talking about is important for everybody. So today's presentation, a little lecture review, is about, I'm going to go over some of the basic dental anatomy of the temporomandibular joint, and craniofacial pain and TMD, nasal breathing, why nasal breathing is important, and I think I have a case review so I can share that with our audience today. So craniofacial pain and temporomandibular disorder, what is it? What are we talking about? Let's talk about the basic anatomy, as we all remember from our preclinical dentistry. We're basically dealing with a bunch of muscles. What muscles we're talking about, for example, is temporalis, masseter right here, and of course the joint. And we have sternocleidomastoid. So these are the muscles of mastication. These are the muscles that allows our mouth and neck, shoulder, everything that to open, close, whether we want to talk, whether we want to eat, whether we want to be able to chew food. So we're using these muscles of orofacial face and the temporomandibular and the mastication to be used all the time. And this is the essence of why we start having so much of a problem, because these muscles starts going on strikes. Temporomandibular joint. So a lot of patients will say, well, I have a TMJ. Well, I hope so, because we all have 2 of them, left and right side. So the correct terminology has been changed many years ago. Is temporomandibular disorder, not TMJ. But for the sake of argument, education of the patients, we still, if the patient comes to the office or read a topic online, I have a TMJ. Well, that's what they mean. They are referring to, I have temporomandibular disorder. So let's correct them on what the correct diagnosis is. But as we all know, what the anatomy of the TMJ is composed of, back in 1940s, was a doctor by the name of Dr. Gill. He divided the joint area into the 7 windows. So all the way from 1, 2, 3, 4, 5, 6, 7. So the right position of the joint should be at the window 4, 7, which means it's in the center area of the fossa. So it's away from the ear canal, external auditory meatus, or stays away from the major bony anatomy. So it's relaxed at this stage. So when we have a panel, let's say, assuming that most doctors at least are able to get a panel, and if you have a CBCT in your office, more power to you, even more diagnostic. But a panel is a good start. I mean, you can see that on the right side of this patient, the condyle is a little bit flattened than the left side. And that becomes a problem because at least on the panel, you're able to see, well, there is a little bit of unevenness of the jaw joint. And that's enough to kind of like raise our eyebrow and say, well, hey, wait a minute, should I worry about this side? This is not exactly the right anatomy of the right side. I know this is normal. So should I ask a few questions about what the patients may be able to share more information? Let's get rid of this. All right. Now, when we look at the normal anatomy, we want to understand, appreciate the disc space. Disc space is basically where the disc cartilage lives, and the condyles are away from the disc space. The disc space is not violated or is not compressed. So we want to be able to understand the external artery meatus, the jaw joint, the condyle is not pushed back against the external artery meatus, because a lot of few innervations that I'm going to talk about it are in this area, which means the patient may start having ear problem, tinnitus, earring, or muffle of the sounds, because there's nothing wrong with the ear, but it's the condyle that is putting pressure on the external artery meatus nerve bundles. So what can go wrong? Well, we can see that the invagination of the bony defects around here on the superior surface of the condyle, right side or the left side. Sometimes you get a little bit of broken pieces of the bone floating in the joint, and the deformation of the condyle. These are all the issues that happens chronically as the patients are or maybe not aware of what is happening in the jaw joint. Different patients, and you can see how damaged the condyle surface is, and you always have to understand how lack of the disc space is almost pretty much existent throughout the entire, not the entire, but most of the patients that we see. You want to be able to understand the flattening of the condyle. This condyle by no means looks like the right side of the condyle of the patient. It's been flattened out throughout the wear and tear. And normal anatomy, we're talking about superior joint space and inferior joint space. So we have the disc here, which is attached to the lateral pterygoid muscles, has two fibers, superior and inferior fibers of the lateral pterygoid, which is connected to the coronoid process. So as lateral pterygoid is a forwarding muscle that pulls the condyle forward, so the disc actually moves forward and backward. Our innervation is mostly on the retrodiscal space, ligaments right here. So the disc itself really doesn't have a nerve or a blood supply to it. And most of the damages that can happen is that the condyle gets in a position so that it's impinging on the retrodiscal tissue or ligament, and that's where the pain of the internal disc derangement comes in. A condyle motion or the rotation, the first 20 millimeter is actually considered as the rotation, and translation happens after the rotation. So actually the condyle rotates and then moves down forward. Articular disc is an extension of the fibrous capsule, as you can see on the illustration. There is no blood supplies, innervation, nerves. So it's basically a bow type. It's like a bow tie, and has the anterior portion that is connected to the superior head of the condyle, and the posterior connected into the retrodiscal. And in different illustration, you can see that the fiber itself is made up of fibrous membrane, and temporomandibular joint and articular eminence is right around here. So at the inner center of it is very thin tissue, is 2 millimeter, posterior is 4 millimeter, and anterior is about 3 millimeters. So which is nothing, 2 millimeter is nothing. So you can understand how compression on the disc can easily perforate the 2 millimeter cartilage, and it really doesn't serve us any function. And incidentally, the meniscus is made of fibrous cartilage, which has a potential to regenerate itself, unlike hyaline cartilage, which is our knees or other joints, which is once it's teared, once it's damaged, is non-repairable. The only way that you can visualize the disc is with MRI. The CBCT doesn't show it, the regular panels doesn't show it. So you have to understand and appreciate the normal anatomy where the disc is actually located or sitting. A lot of times the disc gets to be moved or slides into the medial fossa or can move into the lateral. So the disc is then becomes what we call ligament laxicity, so it's not stable. Or it can move anteriorly, so it's no longer it is what it's supposed to be. And the only way you can see it is through the MRI. Again, normal illustration that shows, for example, the red line is up to a portion that most of the coronal part of the disc can get resolved and damaged. So if you look at the illustration, then this is a normal disc space. And as the wear and tear happens, then the disc space or the condyle actually reduces. So looking at it from the side, you want to appreciate the distance between the external artery areas and the condyle. So all of this is a normal disc space. So we're talking about the nerve bundle that comes from the trigeminal nerve. So one of the more important ones is auriculotemporal nerve, which is on the distal part of the condyle. So a lot of times as this nerve gets impinged or gets compressed on, a lot of patients will complain about tinnitus, ear stuffiness, or issues that are related to the ear, but not necessarily is an ear problem. So the patient may go to an ENT as the first physicians, and the ENTs may look at him and say, well, there's nothing wrong with your ear is perfectly fine, but then the patient may have a vertigo, may have issues with or tinnitus in the ring. But a lot of times, some ENTs, most of them know about the relationship of the condyle with the ear-related problems. Again, when you look at the normal anatomy, keep an eye on the red line, red arrow. So as the condyle goes through the wear and tear, it's getting closer to that red arrow, to the point that by the time it gets to that location or where the red arrow is, it actually becomes corticated. So you lost maybe a few millimeters of the superior surface of the condyle, so it's actually lower. Again, normal anatomy, you can understand how this is going to be developed into the different wear and tear of the normal wear and tear, to the point that from here, we end up having some resorption. So what are we looking at? Well, if you look at this red line where the G, H, and I's are, so we're basically looking at the damages that are happening. Most of the problem happens on the red line. Well, the G, formation of the lip in anterior area, it takes place, breaking of the osteophytes, free bodies within the joints starts being present, bony particles starts floating in the capsule, formation of the subcrystal cyst. Subcrystal cyst means that now you have an imagination of the bone within the condyle. So degenerative joint disease, arthritis versus arthrosis. So we're talking about the disc is no longer where it's supposed to be, and the superior surface of the condyle has been worn down. And in a cadaver specimen, you can see that this is basically bone rubbing against the bone. There is basically, or you can say metal to metal. There is metal to metal. So there is no more disc present here. And what has happened is that the condyle goes through the decortication. So it starts actually becoming decorticated. The retrodiscal space is on the posterior part, and the disc is no longer where it's supposed to be. So if you have a CBCT, there's a lot of good information that you can get from the CBCT. So this is what we call gonial angle deposit. Gonial angles are the corner part of the mandible. and you can understand and appreciate one side, the right side, for example, is more developed than the left side. Well, how does it develop? Is because the masseter goes from the zygomatic all the way to the corner of the mandible. And when we see this as being developed, it's because that masseter is a powerful muscle, is involved in chewing. So every time you open and close, it causes the mandible or the gonal angle of the border part of the mandible to be more developed. Other things that you can look for or visualize is stylet process. Stylet process is this very thin bone that a lot of times as it gets elongated, patients are complaining, well, it may feel like a fish bone stuck in their throat. But in real life, there is this glossiohyoid bone muscle that is attached to this. And as we open and close, the stylet process actually gets elongated. So patients would may not feel anything, or some may, as long as this stylet process is elongated, they may feel like a fish bone stuck in their throat. So that's one clue that the patient may have obstructive sleep apnea. So if you see this on CBCTs, be really concerned that ask few questions about how the patient's sleep pattern is, because that gives you a lot more information. So we're talking about, again, temporomandibular dysfunction, and it is important for examiners to categorize precisely the nature of temporomandibular disorder pain according to the where it is, the site, radiation, development, duration, content, and association, signs, and its impact on the patient's daily life. Because, again, they may experience it differently, and they all have a different way of explaining to them. So let's talk about muscle pain, or what we call it the myalgia, because a lot of times when we palpate the muscles, if the muscles are in pain, we call it myofasciitis. Myofasciitis means the soreness of the muscle. Cervical means the neck and shoulder. So the patient may be complaining about everything hurts. They usually point to the temporalis or masseter, the back of their head. So you have to be able to localize, or maybe bilateral, both areas are having pain, but diffuse dull pain is what they really are relating to. So differential diagnosis is important. Retrodiscitis is when the condyle is actually putting pressure on the disc, on the ligament that has the blood vessels and the nerves, so that becomes painful. Are we dealing with a temporal tendonitis? Temporal tendonitis is where the tendon of the temporalis muscles lands on the anterior part of the temporomandibular bone, or are we dealing with a non-reduced disc space? Non-reduced disc space is what we're talking about. The disc is no longer where it's supposed to be. So are we dealing with a clicking or popping? Clicking or popping is where the disc is actually snaps. These are cadaverous illustration that shows that as the disc is being moved, because the mandible is no longer in a stable position, so the disc becomes ligament laxicity, so disc moves, so that makes that noises. It makes the noises whether on opening or closing. So here we have the popping, here we have the quiet, and here we have the actually gravel sound where there is actually bone rubbing against the bone. So when we talk about the non-reduced disc space, we're referring to the disc is no longer where it's supposed to be. So it's not only stretched forward anteriorly, but the condyle is putting pressure on the retrodiscal space, and that becomes really painful. So a lot of times the patient will say, well, yeah, a few months ago, I opened and I was open locked and I couldn't close my mouth. Well, that's what exactly what happened. The condyle moved into the position. Now they can't go back. So either they have to go to the emergency room, or manually they have to be treated so that they can put the condyle back in their proper position. So the noise actually comes from the fact that the disc moves, whether anteriorly or medial or lateral, that it makes that clicking noises. And every time that they open on the situation of the non-reduced disc space, so you can watch that there is no more midline opening and closing directly on the midline area, so that the mandible actually deviates to the affected side. Here, for example, the mandible is deflecting to the right side, so most likely the problem is on the right jaw joint. So comprehensive examination checklist, what do we look for? Well, you want to be able to palpate the TMJ. You always want to palpate the muscles, masseter, temporalis, sternocleidomastoid master is one of the muscles that rotates our head left and right. Palpate the joint. Capsulitis. Capsulitis means the inflammation of the jaw joint. You want to be able to put pressure right on the joint and have the patient open and be able to palpate the posterior joint space. You want to do a thorough range of motion measurements, measure from the same areas, maximum opening, lateral movement, protrusion. So these are all the important areas. You want to be able to palpate the lateral pterygoid, inferior belly. So with one finger, you can just have the patient close. If they really can't open that much, be able to put your finger toward the third molars, I would say, and go medially. That's where the lateral belly of the inferior belly of the lateral pterygoid muscles are, or you can actually palpate the coronary process right here. So that's where the tendon of the temporalis muscles comes from here, goes through the zygomatic bone and lands over here. So these areas are extremely tender on a patient that have temporomandibular disorder. So that's very easy to diagnose those. You want to have a pain prescription, pain scale. Ask the patient from 1 to 10 how much pain you have. If there are 8 or 10 in an area of so much severe pain, they can close that muscle is really been in inflammation situ. So a lot of times we prescribe a metrodose pack, a steroid to calm the patient while we give him a temporary appliances before we start going to more complete orthotic appliances. You want to be able to check the maximum opening range. Well, what's the maximum opening range? So anywhere from 35 to 45 millimeter is considered to be normal opening. On the limited normal range of motion is anything less than 30 or 35. Some patients come up with 20, 25 limit of opening, so they are able to open that much, and they can't even chew, so the jaw is so much in pain, they're not happy. So again, check and measure the left and lateral excursion, so that's important. Timing is important. When is all this happen? Be able to ask the patient, is it in the morning? Is it after you eat? Is it in the evening? Is it during when you eat? A lot of times patients are having sleep problems. One can experience that they wake up in the morning, and if you ask them, they have, they point to the temporalis area that, when I wake up in the morning, my head hurts. So they point into the temporalis area because the jaw, the muscles have been, the mandible has been working all night. Well, what is it doing? It's been clenching and grinding. So that's a pain related to clenching and grinding. Palpate the muscles, TM. You want to be able to have them open, close, and listen. If you have ways of detecting noises in the jaw joint, we use JVA, which stands for Joint Vibration Analysis. So it picks up any friction in the jaw joint. Feel the palpation while you're doing that and listen to any noises. Some are very audible. You can click, you can hear the clicking of the jaw joint, and the movement of the jaw is important. So during the intake questionnaires, I have this basically the left column and the right column. So we ask the patients to identify the top 4 things that they have problem with. So let's say I have a headache, I have an ear pain, I have a neck pain, or any one of these things that they click 1, 2, 3, 4. So that gives me an idea of what am I looking at, how am I going to be able to start helping the patient. Or if they are clicking anything here on the right side, well, these are mostly sleep related. So do you wake up in the morning, tired? So the 3 questions that I ask the patients that identifies whether they have a sleep-related problem, which you can easily do it in your practices, is to ask 3 questions. Number 1, how long does it take you to fall asleep? If it's more than 20 minutes, then you're dealing with insomnia. And as a patient, you wake up at night. Well, yeah, 3 or 4 times. Well, that's not normal, because if they go into the bathroom, so that's the signs of a sleep-related problem. In pediatrics, very, very big deal. I mean, that's a whole different lecture about pediatric obstructive sleep apnea. As the patients, you snore. Snoring is alarm that there is a smoke somewhere, and there's a fire somewhere. Smoke is basically a snoring. And if the patient's saying or telling you that I wake up in the morning, or I have a hard time waking up, or I'm not fresh in the morning, then the patient is not going through a deep sleep. They're not getting a REM sleep. Or if they're tired during the day, like around 3 or 4 o'clock, but that's an indication of the circadian clock is not, basically it's kicking in around 3 or 4 o'clock. So there's a lot of clues that you can ask and find out.
Yeah, I'm 25 years old, and even since high school, I've been having pretty severe headaches in my temporal areas, and a lot of tension, and as well as just a lot of tense neck muscles and shoulder muscles, and waking up with back pain when I wake up in the morning, my lower back, and also just recently, my jaw pain has been pretty bad, and the muscles here have felt very tense and tired, and especially I feel like during the day. And I've also had sometimes even when I'm exercising, I'll get dizzy and feel like I have to stop exercising after a little while. And even sometimes when I'm doing push-ups or something like that, I'll get little shocks up my neck. So I went to a dentist previously, and they had recommended that I go see an orthodontist. That orthodontist suggested I might have TMJ, and wanted to do braces, and I wanted to explore.
I've been having TMJ problems for 5 years now. It started when I woke up one morning and I was clenching my teeth, and like it felt like I had a bullet in there. And I went to a few maxillofacial surgeons, and they just gave me a mouthpiece, but it didn't work out because they weren't monitoring my process or anything. They just gave me that, and it just made the problem even worse because I was removing it and putting it back in and removing it, and it just made my entire neck area, my jaw, my eyes started feeling like they were getting into the condition too, and like my entire face just started feeling like kind of numb. And all I could do was pretty much come here to the TMJ Center and look for a newer solution, and they have really good therapies for it.
Hi, when I first came to Dr. Ariz, I was having jaw pain, tinnitus, and a lot of difficulty sleeping. And I was taking Klonopin regularly at night to help with that. And since I began treatment, I've noticed a marked difference in my ability to fall asleep and stay asleep. I'm off the Klonopin, and I no longer have painful jaw clicking, and I don't grind my teeth nearly as much as I used to. And when I do, I notice it and easily stop because my jaw is much more relaxed.
So my name is Amit, and I have TMJ. And I came to the clinic because I was having a lot of jaw pain. I wasn't able to chew food properly. I wasn't sleeping at night. I was grinding my teeth a lot, and I was just having a lot of pain. It was a lot of discomfort. And when your jaw is hurting, it pretty much affects your whole life because you can't eat properly, you can't talk. Every time you yawn, every time you do anything like with your mouth, it basically hurts a lot. So
I was first recommended to TMJ Therapy Center by my regular dentist. I came in on the first day. I had pain. My jaw I couldn't eat, and I had all this tension in my face. I was having headaches just about every single day, and it was really affecting my way of life.
So, yeah, these are all the problems. These are all problems that you hear them firsthand from the patient's mouth, because that's how they express their issues or discomfort, because pain and sleep, they go hand in hand, And, a lot of, unfortunately, physicians are very easily prescribing Klonopin or sleep medication without even realizing or understanding, well, this patient might have obstructive sleep apnea. But pain and sleep, they're very much roommates that they live together. So, but what happens, let's talk about let's get back to the temperamental problem, is that we bite up to 5 times or 7 times harder at night because we're unconscious. So we're not able to detect how much pressures are we forcing on the condyle. So if you look at the cant, the jaw joint may not be exactly, the mandible is not exactly parallel to the floor. You want to be able to look at the craniofacial eyes, and as we know, 70% of the craniofacial development happen up to 7 years of age of when the kids are developing the growth. Look at the eye. You want to look at the ear planes, and you want to look at the occlusal planes. So if you visualize, you may see a pattern of the disharmony between the eyes, ears, and the mouth. So, and the patient will say, well, yeah, I've noticed always why my face is crooked or I'm not, smiling the right way. Well, because what happens is that the forces of occlusion, you want it to be mostly balanced to the left and right joints. And when there are imbalance, so one area may be exerting more forces than the other. So that's where the craniofacial pain starts, because one side is under tension, the other side is not, and is carrying, and the whole posture, the whole body anatomy changes. So if you look at the mandible, imagine an airplane. So you have a yaw, roll, and pitch. So the mandible is actually in 3-dimensional. It can rotate forward, backward. So it's not a 2-dimensional entity. It has all these rotations. And you can see the cant. You can see the one side, if you have a CBCT or if you have iTero, you'll be able to see one side is actually occlusal-wise is closer to the other than the other side. So that's basically what you visualize. You're visualizing the anatomy, not inside the mouth. So if you have a CBCT, you always want to look at the anatomy and appreciate it. So if we dissect the anatomy out of the image and put it on the grid, yes, the condyle on the right side is higher than the left side. Doesn't need to be by inches, even a few millimeters. That creates tension on one side versus the other. If you look at photos of a normal patient, just give them a tongue blade. Just have them bite done, and you may not detect the abnormality on the left photo, but as soon as you put a tongue blade in the patient's mouth, you can see, wow, this is definitely canting to the left side. And this is a CBCT of this patient you just saw. And you can visualize, if you take away the muscles and the tissues away, that's what you're looking at. This is what the patient doesn't see. And this is her condyle. Look at the area that is affected versus the normal condyle of the right side. So, and look at the wear and tear. Look at the flattening, is what we call flattening of the superior surface of the condyle of the left joint. So a lot of journals, including JADA, has talked about the definition of craniofacial pain is inclusive of the musculoskeletal pain, orthopedic inflammatory disorder of the TMD. So a lot of times patients are complaining about headaches and migraine or tension type. So what is a headache? What are we talking about when we're talking about the primary headache? Well, primary headaches are considered as a tension type number 1, because unless you get hit with a baseball bat or a trauma. So primary headaches, number 1 being a tension type, and that usually happens because of the mouth breathing. Patients been breathing through the mouth all night, so they're opening, closing their mouth. Most of the headaches, which are tension type related, are related to the muscles, masseter, mostly, or temporalis. At number 2, cluster headache. What's a cluster headache? Cluster headaches are RAM-related sleep, obstructive sleep apnea. Patients that are dropping on the CO2 saturation, and they have a problem. And number 3, a lot of times on the intake questionnaires, patients talking about, I constantly have a migraine headache. Well, migraine is systemic, it's metabolic. It talks about, or is related to the food, leaky gut, which means the gut, the lining of the intestine is permeable to the proteins that are leaking through the stomach, and it creates an autoimmune disease in the body So anything from the psoriasis or the eczema or anything that becomes autoimmune has the origin of the poor metabolic or nutrition. So that's where the migraine headaches can be easily prevented by improving the health of the diet of the patient's eating habit. So the incidence of the temporomandibular disorder, who has TMD mostly? Well, it's mostly women. Peaks around 20 to 40 years of ages, and mostly in females. TMD increases in parallel reproductive function, decreases in the menopause, when ovarian production of estrogen decreases. TMD pain is about 1.5 to 2 times more prevalent in women. Females are able to generate significantly higher TMJ pressure than men because they are grinding more. So most of my practice, in my practice, patients where I see most are women, they have sleep problems. Guys are usually sleep related because guys are more macho. They don't really complain about the jaw problem. Women are both TMD and sleep related problems that we see. So what happens is that our body's anatomy changes. So if you look at the ideal posture, you want to be able to see the ear on the shoulder line. So the neck is basically upright and straight. On a chronic forward posture, what we're referring to that, the location of the ear is not on the shoulder, so it may move or maybe about an inch forward of the shoulder. So what happens, you start carrying the weight of the head and neck on the shoulders. So for every 12 pounds, that let's say your brain, your head, everything that it weighs about 12 pounds, then if you increase 1 inch forward, you actually you can go up to 2 inches. You can double the weight of the head on your neck and spine. So a lot of patients will have neck and shoulder problems, and you have to be able to understand, well, it's no longer the head is carrying on the spine. The shoulder muscles are tight. The more shoulder muscles are involved. So what happened? Well, the patient starts having sternocleidomastosis. So if you palpate these areas, these muscles are sore. But if you start palpating the shoulder, neck, and back of the head, so the tendon of the trapezius muscle is sore. So these are the patients, these are the areas that the patient are constantly complaining about. And again, this has nothing to do with dentistry. But I want you to be able to understand, if they complaining about the neck and pain shoulder, palpate this area. They often are more inflamed and intended. So when you look at their postural, this is a time lapse of the patients as they've been getting treated. So you can see the head upright. So actually, the ear comes back to where the shoulder line is, and as the posture improves, the breathing improves, because now we concentrate on the breathing, which is related to postural correction. So before treatment, one can appreciate, let's say this ear is about an inch or so forward the shoulder, and after the treatment, the ear is pretty much aligned with the shoulder. So this patient is uprighted more. So things that you want to, the clues, the sign that you want to ask patients, what are the signs, some of the signs and symptoms? Well, chronic headaches. If the patient's check mark on your question is, I have a constantly headaches, or ear ringing, ear congestion, facial pain, popping, jaw joint noises. So these are all the questions that you can have on your intake dental or medical questionnaires, or just ask patients. The 3 questions that I said earlier: how's your sleep? Clenching, I grind my teeth. I have neck and shoulder pain. I have limited range of motions. So you can always do these exercises or ask these questions from the patient. So tensions, they always referring to the neck shoulder pain. So you just saw what happens, and so the pain on the neck and shoulder actually can radiate to the arms. So they start feeling the numbness of the fingers, but it's because the cervical area, there's the nerves, C1 to C7 that are exiting through the vertebrae are being impinged because the forward head posture. So trigger points is what we do. Trigger point injection is basically delivering of the steroid, muscle relaxant, and anesthetic into the key areas of the muscles that are inflamed. So, for example, the sternocleidomastoid, so these areas. and back of the head and trapezius or temporalis, a lot of times us as a dentist, a patient may may be complaining about, I have a tooth pain, I have a problem with my number 4 or bicuspid or premolars. Well, you look at it, you take a PA, there's nothing periodontally, there's nothing endodontally, the tooth is perfectly vital, there's nothing wrong. But you have to understand the anterior fibers of the temporalis is basically gives a referral pain to number 6, 11, or the premolars. The middle fibers actually refers pains to the bicuspid, and the posterior fibers of the temporalis can be referred pain to the molars. So palpate these muscles. If these areas are tender, then that's a clue that you really don't have anything clinically wrong with the dental anatomy itself. Again, the posture, good posture, all the way from lordosis to forward head posture. So all of this stuff, you can just be on the airport and just imagine how patients are walking around. So understand the anatomy of how biology, how anatomy distorts our body, because the forward head posture, the head has to go forward because of improper nasal breathing, the posture changes. So the axis of gravity changes. If you look at the normal anatomy, the spine is actually not erect anymore. And whenever you look at the front or from the sagittal view, you can see the mandible starts with our just can't not be in the right form. The eyes are not in the same shape. The shoulder line is canted, the hip is canted, the knees and the posture, the feet are deviated going to the left and right. So through the course of our treatment, we're able to actually get them uprighted and more balanced shoulder, and when they stand still. So again, the ear, you want it to be on the spine or on the shoulder line. So a lot of chiropractic or osteopaths work is related to what we do. So it goes both ways. We have patients that are coming from the acupuncturists, from osteopath or chiropractors that understand osteosacral relationship, and we can help the patient get better faster. So how do we treat? How do we treat is with orthotic appliances. It's not night guard. So occlusal splints has been in dentistry for many years because they are able to relax. We're talking about decompression therapy in the jaw joint, decompression therapy in the muscles. So lots of articles have talked about how orthotic appliances can help. So this is, for example, one of the daytime appliances that we use, and the patient wear this for 10 to 12 weeks. So what happens is these appliances are correcting the cant. So if the jaw joint is not stable, is one higher than the lower, the other side. So these orthotic appliances are able to deprogram the joint, relax the muscles, and as they come in every 10 to 12 weeks, every other week, so we basically correcting the anatomy of the contact on these appliances. So there are posterior centric contact, and there are basically anterior position appliances. So if you have a patient that, let's say, have obstructive sleep apnea, if we're dealing with a patient that needs to be decompressed at night while they have a sleep-related problem, how do we detect that? Well, they have to be identified through a sleep physician. So we give them a HST, home sleep test, or they have to go to the lab for polysomnograph. So one way or another, the result comes back from the sleep physician. So we as a dentist are not authorized to diagnose obstructive sleep apneas, but there are so many different categories. There are 7 different sleep categories according to American Academy of Sleep Medicine that categorizes the patient. So let's say a patient comes back mild or moderate OSA, so we are able to place the orthotic appliances, and there are over 250 FDA approved appliances out there. So these appliances are very thin, they do amazing jobs. So but which one is right for you? So the point is that you want to be able to decompress the jaw joint at night while you're treating the obstructive sleep apnea. So what else do we do? Well, we do Prolo injection. What do we do with Prolo injection? Well, Prolo injection is basically an anesthetic and saline, which is delivered in the jaw joint, creates inflammations, and after inflammations is created, the body actually takes over and starts healing the process. So we use this a lot for a patient that has jaw joint clicking or ligament laxicity. So it stabilizes jaw joint. And lasers. This is from a company that right here in the US that manufactures them, and they're able to decompress the jaw joint by reducing the inflammation. So we use that in the joint spaces. We use that in the muscles, back of the shoulder. This is a patient that we saw a while ago. Close again. Open again. So you can hear the clicking, as this is what we call deflection. Deflection actually, when the jaw joint goes to the left and then comes back, that's deflecting. Deviation is basically just going to the one side. So are you dealing with a patient that has a deflection, or are you dealing with a patient that has a deviation? So this is after 10 weeks of treatment. So you can see they're opening, closing more normally, and they're able to open even more. No noises. And again, these are one of the other patients that we saw. So this is the photo on the left side is the first day the patient came into the office. So you can see from their face that they're in pain, they're in agony. And this is just a little bit of review of how she felt.
Hi. So when I first came to Dr. Ariz, I came because I was not aware that all of the pain that I was feeling was from TMJ. I thought this was all sinus pain. So my doctor told me to come see Dr. Ariz, and he did the full evaluation. And the day I came in, I was in excruciating pain, and I had been in excruciating pain for months, actually, just not realizing what it was coming from. I was so tired all the time. I had constant jaw pain, earaches, headaches, migraines. I couldn't even look at light. I walked around like this with sunglasses inside. It was horrible. I was in excruciating pain. So after 10 weeks, maybe 11 weeks with Dr. Ariz, all of my symptoms are completely gone, which is fascinating to me. I had no idea that 10 weeks with these appliances and just doing the small adjustments could make such a big difference. And my life is completely done a 180 from being in total pain to being in no pain and being able to sleep. So thank you, Dr. Ariz, so much. Thank you.
So again, a quick overview of the nasal obstruction. Where is this all coming from? Well, it's very simple. It goes back to the nasal anatomy. This is an article that was published a few years ago in Illustrating that talks about the nasal obstruction may alleviate paroxysm-related temporomandibular joint disorder. So I didn't want to include a lot of articles because that would be boring presentation. So, pain and sleep goes hand in hand. Like I said before, they both live in the same room. Consider them as a roommate, because if you have pain, you have a poor sleep, and if you have a poor sleep, you have more pain in the morning. So they ongoing cycle. And so it's important to diagnose: are you dealing with just a patient that has a sleep problem or pain, or simply both? This is an article that talks about 4 points of obstruction. What do we care about obstruction of nasal cavity? Well, let's look at it. Well, door number one, we call a nasal valve. When it is collapsed or when it's narrow, we're having a harder time to breathe through our nose. Door number two is soft tissue or superior, inferior, and middle turbinates that are inflamed or deviated septum. So if you have deviated septums, or if you have inflammation of the turbinate because of the food or allergy that increases the volume of the nasal cavity, you have a harder time to breathe. Door number three is a soft palate. If it's low draping, or if it's within normal limit, that's a problem. If it's causing that problem. And door number four, if you have an obstruction of the tongue on the airway. So any one of these four issues, then the brain goes on a survival mode. You are opening your mouth to breathe, because if you don't breathe more than 2 minutes, guess what happens? So we become a mouth breather, and that's the essence of creation of the temporomandibular disorder. So we start having jaw problems. So let's look at the normal nasal anatomy. This is the nasal valve that the patient has, and these are, we're going into the nose, so these are number 8 and 9 coming to the play. You want to be able to appreciate the normal nasal valve left and right side as we go in deeper, so appreciate the normal nasal septums. and we're going in deeper. So these are the lower inferior turbinates, left and right, beautiful. If this is swole, if it's inflamed, we call that swole bodies. Again, superior turbinates are nice, maxillary sinuses are beautiful. So this is a normal anatomy. Look at the airway. This is beautiful. But when we start having deviated septums, look at this deviation. Look at these problems. You see, the nose, the anatomy is changed to the point that one side is hardly able to intake air. The right side is, the left side is much better. So if you are not filling your lung with enough air through your nose, because 70%, the air that we breathe has to be moisturized and gets to the lung nowadays with COVID and gas and pollution in the air. So your nose does a tremendous amount of work. So this is a nose of a patient that hardly has any room for breathing. So therefore, your body goes on a survival mode. You're a mouth breather. This is a conchoblosum. Conchoblosum is a air sac within the nose. It's a normal anatomy development, but it's not normal for everybody. It's normal for this patient. So it creates extra volume. This is normal, and this is not. So if you have a patient that has both deviated septums and conchoblosum, again, the body and the nose goes into the least path of work, which makes you a mouth breather. Again, severe bending of the nose. Okay, this is the different section of the same anatomy within the same patient. So every patient that you have a deviated septum, ironically, you have a jaw problem. Again, this jaw joint on the right side is distalized, is where it's putting pressure on the nerve bone, the auriculotemporal nerve that we talked about earlier. I just want to do a quick case review. I think we have some few minutes left. So this is a patient that was referred to me by a neurologist. Her problem was that she had, for years, she had trigeminal neuralgia. Trigeminal neuralgia, as you know, is involved in trigeminal nerve. And this patient has seen neurologists, have been checked out with MRI. That is not a problem, that they can help. So I started treating her. So look at her questionnaire. So everything on the left side is checked. Everything on the right side is checked. So right away, we're dealing with a patient that has a sleep problem, was never told that she has sleep-related problems and takes medication. And she's checking on almost every box or category. What is she taking? She's taking Tegretol. This is for trigeminal neuralgia that she's been put on by a neurologist. The medical history, let's look at it more closely. She has depression. She has dizziness. She has anxiety. Asthma. So these are all right away. I can tell that this patient has a nasal problem. This patient is not sleeping. Look at the sleep section. She has a migraine. She has nervous disorders. Again, high blood pressure for such a young individual. That's alarming because if you have a sleep problem, then you get into what's called nocturnal dipping. Your blood pressure does not dip in, so you have a high blood pressure constantly, daytime and nighttime. You increase cortisol, so your body is almost in the fight or flight mode. So on our diagram, we have a section that refers to where is it hurting. So you want to be able to identify and categorize on your initial intake questionnaires where they are related. So this is the 3 or 4 page SWOP report that we provide to the referring dentists and the physicians, which goes all the way from their chief complaints and anything that we do, which is looking at the sleep, the postural, the normal anatomy intake questions, so the muscle palpation, what do we find, what's normal, what's not normal. So all these reports will be sent to the referring docs. And what is it basically that we're doing? Well, our game plan for her was to treat her, decompress her jaw joint in daytime while we're helping her because she was diagnosed as in moderate obstructive sleep apnea. Moderate refers to anywhere from 15 to 30 AHI. Anything above 30 is considered severe. So with mild to moderate, we are able to help a patient with improve their sleep quality because the mandibular advanced devices will definitely help them. So let's look at some of the clinical photographs. So again, can to the right side. So this is her inflamed tissue. She's not really paying attention to her oral hygiene. So what do we look for? We want to make sure that the patient doesn't have any tongue tie. This one, in this case, she doesn't. You want to understand, appreciate the skeleton of the tongue. This is what we look for. So what it is, basically, you get the footprint of the teeth on the tongue. So as the tongue is actually expanding at night, you'll be able to get the footprint of the molar or premolar on the tongue. Look for the white coated surface of the tongue and look for the malum pari. Malum pari is when you have the patient stick the tongue forward. If it occupies the majority of the airway and you can see the uvula, that's malum pari 4. There are 4 categories, malum pari 1, 2, 3, and 4. So in this case, she is number 4. Look at the raising of the tongue on the floor of the mouth. Again, white coated surface of the tongue. Look at the uvula and appreciate the tonsils. The tonsils in her case, grade 2, so which means her nose is not working. The tonsils are filtering the air which the nose should be filtering. So left and right, we always want to document the anatomy of the teeth and upper arch, lower arch, overbite, overjaw. So these are the routine photographs that we take on intake patient questionnaires. So the yellow shirts that she's wearing, this is the day 1, and this is after 10 to 12 weeks, and you can see how the ear has moved backward because the head has been more uprighted, both from the front. You look at the front and sagittal views. And this is her oral appliances at night that we recommended for her. These are anterior guidance, and for a patient that have TMD and sleep-related problems, so we put them on anterior discluding so that the back teeth are not touching. If the back teeth are not touching, there is no shoving the jaw joint upward, and these bands should be changed every 6 months or as needed. Oral hygiene improves by the time we're done with her. And I think this is her video.
Hi, my name is Ria, and I'm a patient here at the TMJ Sleep Center. I started here because I was struggling with trigeminal neuralgia, which is a very, very painful nerve condition in the face. I couldn't drink water, I couldn't eat, I couldn't talk, I couldn't do my job, and I had ran through a dozen doctors to see what was wrong with me, and I wasn't getting any answers. So that's when my neurologist referred me to Dr. Ariz, and he did a full evaluation on me, and turns out my problem came from my sleep, from my breathing when I sleep, my anxiety, my stress. It came from a lot of things that I didn't really consider. So from then on, Dr. Ariz put me on a treatment plan with a day and a night appliance and a sleep machine to get my sleep in order and to realign my jaw so that when I breathe at night, I can get proper breath, I can get proper rest, and I can get proper restoration when I'm sleeping. There are so many people, and there are so many people in my family that don't sleep correctly, but they just accept it and they just go on with it, and that creates problems later in life, like it did for me. But I'm so grateful that this treatment plan worked for me. It took about 13 weeks. I am now full-time back at my job. I was also a student. I'm a student again. I had to medically withdraw because of how painful my condition was. But I'm back at school, I'm back at work, I'm going to the gym, I'm more active, I'm more alert now. I used to have no energy throughout the day. I used to be such a groggy person, but now I can go through my day and have energy and wake up and have, the will to go through my day instead of just like waking up and being super tired. So I'm so thankful to the TMJ Center and to Dr. Ariz and to the whole team that works here. They are super, super nice, and they're just such amazing people at taking care of you. They don't want to put you on a million pills. They want to just have you heal correctly and get you back to where you were. So if you have any issues with sleep, please come here, even if it's for a consultation. I promise you, you won't regret it. So yeah, thank you so much.
All right, so I think we're getting close to the end. So again, the take-home message is to identify, be able to see and realize what you really haven't. And again, I just hope that I brush on some surface of the topics of temperamental disorder, because like I said, it's not dentistry, and it's beautiful, but because it bridges the medicine to dentistry. So for anybody that is interested, again, on May 11th, feel free to contact me. I am going to be going much more detail of what I just talked about today, how I'm able to help patients. And I'll have my email here at drariz1@gmail.com. So if anybody's interested, shoot me an email. I can have flyers or arrangement made for you to be my guest at May 11th. So with that, Dr. Shah, I think I'm on time. Hopefully, I'll be able to answer any question that any of the docs have, and I'm ready for you taking over.
Thank you so much. That was very interesting. Doc, one question that's coming in is, do you believe that sleep apnea can trigger cardiac arrhythmias
Yes, of course.
in otherwise healthy patients?
Well, yeah, I mean, cardiac arrhythmia and sleep, again, you have to understand the physiology, which goes into much more detail, but you're putting more stress on the heart. And the endocrine system, the cardiovascular, so everybody is working harder because what is not happening is your body is not at rest when we're supposed to. So just sleeping doesn't mean that you're sleeping. You have to be able to get into that REM sleep. So being in a deep REM sleep is not good enough, and being in a light REM sleep is not good enough. So you have to be in certain categories. So again, if your body is not rested, then different patient exhibited differently. So cardiac arrhythmia and high blood pressure, cardiovascular problems. So these are all relationship that they go both ways and causing problem for patients. Sure.
So on immediate pain management, I understand, for instance, I have a patient I referred over to your office, or a local TMJ specialist, which are rare to find. How do you manage the patient's pain while you're doing all the workup, while you're doing your analysis and the medical history review? These people are in a lot of pain sometimes, and I have had some pain in the past in the TMJ, and it's not very pleasant. It's very aggressive. What is your recommendation there?
All right, let me just stop sharing here. Okay, I lost you here. Nope, sorry. All right, can you see me?
Yes.
All right. I was just trying to. Well, yeah. So what I do as a triage, if let's say a patient has limited range of motion or they can't open, so we put them on steroids. A metrodose pack 4 milligram. They decrease on the dosage for 7 days, and then we give them anti-inflammatory NSAIDs, and we give them a temporary appliances. So basically, we're able to manage their pain. Do my intake questionnaire, which takes about 2 hours or so, and go through the reviews of CBCT, intraoral postures, and everything. So once they're on board, then we are able to do the digital image scanning, send it to the lab, because these appliances are not ready within a week or so. So it takes some time. But meanwhile, I'm able to treat them. We help them with the temporary appliances and improve the nasal breathing, and triage them until the appliances get here. So then that's where the 10 weeks starts after that, but they will get better right away. So there's multiple different treatment that I can do, whether it's prolo injections that we need to open up, unlock the jaw joint, or do the laser, or there's so many different things, but they will start getting better right away. But assessing them and treating them, doing the triage is the key thing, yeah.
So in any discipline of dentistry, it's not very hard to seek continuing education. I mean, if I'm into the aesthetics, if I'm into implants, into pros, I can readily seek out good, valuable continuing education. But with TMD, sleep apnea, you don't run into that much. How would you say a colleague that wants to get started in this space, where should they start? Who should they reach out to? Are you offering more courses? How does this best work, you think?
Sure, sure. Well, yeah, I mean, good question, good point. Yeah, well, again, like I said, this is not taught in dental schools. I mean, dentistry pretty much has nothing to do with what we do, but this is orthopedic abnormality, because your jaw joint is another joint. Your knee joint is a joint. So when you have a knee problem, you go to an orthopedic surgeon, what happens? Or they give you soft casts, or they give you crutches to take the pressure off the joint and the knee joint. So in our world, just because we happen to be dentists and TMJ falls into our realm of this practice, so we treat the joint as with the orthotic appliance. So that's why the night guard really doesn't do that, and it goes into different techniques of why night guard doesn't work. But for continuing education, anybody who's interested, so we have a program, the mini residencies, that is provided by a founder, which is Dr. Stephen Olmos. So he's in San Diego. So I definitely highly recommend. So if anybody's interested, contact me, send me an email. And he has these programs, he has these continuing educations that he does it. And there's one coming up, I think it's in June. There are 3 residency programs, mini residency 1, 2, and 3. So by the time you go through that residency, I mean, that's what I started my initial careers, and then you educate yourself. Your education for anybody never ends. So we can't really say we know everything there is, everything there about our field. So we're always educating ourselves. So I highly recommend any dentist, anybody that is interested to go through this training that I went through, to educate yourself, to be more updated as far as what you can do and provide services for your patients. But the least you can do, I hope today, is to understand how at least know a little bit what I didn't know before, how to see the abnormalities in the patient, the questionnaires, to be able to talk, communicate with the patient. And let's say if you're close to me, yeah, I can definitely help. If you are not close to me, again, there are centers that are different part of the world that perhaps they can help get some relief from your patients. Yeah. Does that answer your question?
Yes, excellent. So you're well established in LA. I'm, for example, in Palm Desert, and there's only one guy that looks at TMD and TMJ. Most oral surgeons don't want to have much to do with it around here, so it becomes kind of tough to manage these patients from time to time. So when all else fails, and you've done your therapy with appliances and gone through all of those modules and steps, surgical intervention is pretty invasive, right?
Correct. Yeah. I mean, I basically have turned around and discouraged patients that came in for a second opinion for surgery, because arthrocentesis, for example, lots of studies have shown that they might be better for first 3-4 months, but the pain actually comes back. And introducing steroid in the joint is a bad idea, because that causes other issues that may have. So the jaw problems is not really something that you want to start going in and mess around with and go through the surgery. So surgery might be important for patients that have lost conduct or have the other diseases that are destroying the joint, but we're not getting into that. But I would say 95% of the patients that I'm seeing is just basically manage and understand the anatomy and what are you able to do. So, if you have again, I'll go back to the knee joint. If you have a knee problem, no one's going to cut your knee away. So you decompress the joints. You do such treatment until the body heals itself, and that's basically the essence. I mean, if you have a lot of times we see a patient that come in with the right side of the jaw problem, and I look at the CBC, the left side is already gone, bad. And I looked at him and said, hey, listen, your left joint is worse than your right joint. You should be worried about your left joint. Well, no, I'm here because of the right. Well, the body goes again, this path of resistance. Now it understands the left side was a problem. You never did anything. So let's pick on the good side, which is the right side. So now you're here because the right side really radiographic, it doesn't have any problem, but it's the left one that, you never did anything. Now it's the right side. It's almost like flying with two engines, you have one engine on airplane goes out, and then, your airplane has to work on the good engine. So, but again, it all makes sense because surgery is not the solution, and I have helped a lot of patients deter them from getting a surgery because it's not going to help them.
Wonderful. Just what I wanted to hear. You are actually addressing the etiology versus the symptoms, and that's good. That's what you have to really understand the problem.
Again, it goes back to how all of this was, made sense in our healthcare, because Dr. Olmos was one of the pioneers, and he still is the one that actually distinguished the anatomy of the nasal breathing, how it's related to this function that we have nowadays. I mean, because it makes sense. There's two ways you're going to breathe: the nose and the mouth. If I block your nose, how else are you going to breathe? You're a mouth breather. So if you understand and categorize, okay, what signs and what clues do I have to look for in mouth breathing, and how I can prevent that, because 99% of what I do is addressing the nasal breathing. True, I refer patients to ENTs that understand the proper nasal breathing, and some ENTs totally bypass the nasal valve collapse, like I showed you on that slide. So they correct the septum, or they may correct the rhinoplasty or septoplasty. So they correct the nasal problem, but the patient door number one is closed. It's not open. They can't breathe through the nose. So the ENTs that I'm talking about, they understand the 4 points of obstruction. Door number one, number two, number three. All of these doors has to be open to be able to functionally be able to breathe, have the patients breathe day and night. And we go back to not necessarily everybody needs to go have a nasal surgery done. There's a buteco breathing techniques that I work with patients, which we can show them, teach them how to breathe through the nose. So if they can breathe through the nose night times, day times, and now they're much more in control. So the orthotic appliances, they come and go basically in 10 weeks. So resets the jaw joint, but the fire is in the nose. Again, it's in the nose. So if you can manage the nasal breathing, reduce the inflammation, how? Healthy diet. What diet causes inflammation? Sugar, dairy products, gluten, pasta, things that causes inflammation, swelling. The last place that you want swelling is your nose. Because like that other side that I showed you, so if you have inflammation in the nose, you can't breathe, and you go through muscle conditions that are constantly working, your mouth breathers.
Excellent.
Yeah.
Very good. That was very exciting. It was truly an honor to have you here with us. Very impressive. Thank you so much, Doctor. You said you're an example of what can be said from a dentist to a periodontist to a TMD expert, and on. You continue to spread knowledge and information on top of all the executive roles you hold, all the educational endeavors you have. Very glad to know you, and hopefully you come back in the show, maybe give us some updates or new findings that might be relevant to this topic that our colleagues can benefit from.
Be glad to. Thanks for having me.
Thanks so much, Doc. Have a great Sunday.
Bye. Take care.